The content discussed in this episode may be specific to the guest's organisation or location and may not be applicable to other organisations, states, territories or countries. The material presented in this podcast is for general information purposes only and should not be considered health, legal or financial advice. Medical administration is a rewarding profession, but it comes with challenges. So what is it like, and what should you do if confronted with a monumental administrative difficulty? This is the podcast that takes unfortunate scenarios and explores the essentials of clinical governance to find solutions. I'm Dr. David Rankin, a very experienced medical administrator and lead fellow with the Royal Australasian College of Medical Administrators. And this is Safeguarding Healthcare, the essentials of clinical governance. Today, a bully in theatre.
Healthcare is like a pressure cooker at times.
That's Professor Matt Sabin, most recently the Group Director of Medical Services and Clinical Governance at a large private hospital in Melbourne, and I'm presenting him with a difficult scenario.
The first thing that I think of is that doctor okay?
In today's scenario, you are the medical executive at a large private hospital. The Director of Nursing comes to your office for advice as she has just met with a distraught theatre nurse. Apparently, a senior urologist became upset when the nurse did not understand their request for a particular instrument. The interaction escalated to the point where the surgeon shouted, swore loudly, and said he was not prepared to have the nurse work in their theatre ever again. The nurse was very upset and left the theatre, potentially compromising the completion of the surgery. It is not the first time this has happened. You had met with the surgeon after a similar outburst several months ago. At the time, he expressed remorse and gave assurance that it would never happen again. Given the surgeon's commitment, you gave the Director of Nursing assurance that this type of incident would not be repeated. I start by asking Professor Matt Sabin what major challenges are raised for a medical leader in this sort of scenario.
I think this is quite a common scenario, unfortunately. Healthcare is like a pressure cooker at times, and everybody comes to work to do the best thing, but frustrations can occur in the workplace. It goes without saying that, of course, the first thing that we need to make sure in those kind of scenarios is that the patient's safe and that the appropriate care is being given to that patient. We clearly need to make sure that the impacted nurse is okay and make sure that the Director of Nursing has provided that support through the line manager and that that person's got immediate support both internally and also through the employer assistance program that's available to hospitals. Then as the medical director, there's more of a grappling issue in terms of how to manage this, and I always reflect back to Professor Alan Sanford, who was one of the presidents of the college, that when he was giving us a talk said, as the medical director, you need to think of the medical staff in your hospital as your patients. And I think that's a really good grounding for a medical director post. It allows you to think about wandering around the hospital, doing your ward rounds and seeing the senior medical staff. And so when I hear about an incident like this, the first thing that I think of is that doctor okay? Sometimes we find that, doctors, like every human being, have things going on in their life that they may not necessarily talk about, and it might come out as anger or inappropriate behaviour in the workplace. It's really important that you act on it immediately. And so I would always pick up the phone and phone that doctor and say, I've heard of an altercation today. Can you tell me what happened? Are you okay? And what's going on? I wouldn't do very much in that first conversation. I'd really just want the doctor to know that it had been escalated to me and that we were looking after the staff as well as him or her, and make sure that that doctor's okay. And then I would arrange a time to meet with them sometime in the next few days when they've had a chance to calm down and reflect. Sometimes they come to that meeting and they say, look, I'm really sorry, I was really stressed that morning and it was me, and I'll go and apologise to that staff member. Things get a little bit more difficult if the visiting medical officer starts to say, actually, this is not my issue, this was the nursing staff member, and then it comes down to successful negotiation.
How do you go about telling medical staff in a hospital what is acceptable or unacceptable behaviour? How do you lay the ground rules?
So within a private hospital, we have what's called the bylaws. So the bylaws obviously talk about what's acceptable behaviour, but as part of the bylaws, all of the visiting medical officers, they need to abide by the policies and procedures of the organisation, and that's generally outlined in terms of the bylaws. So they have the same requirements as any staff member would in terms of complying with a code of conduct or organisational behavioural standards.
Doctors work as a team. In this scenario, we've got a surgeon whose behaviour has impacted on the nurse's comfort to the point that the nurse has left the theatre. What behaviour is acceptable, I guess particularly in a crisis, versus unacceptable in a routine procedure?
The first thing that I would always say to a doctor who's gone through that scenario is, can you tell me the circumstances? What was going on in your mind? Is everything okay? Provide support to that doctor. That doctor might be struggling for various reasons, perhaps the complexity, the acuity of the case. Talk around that. Talk about his or her own professional and personal obligations. How much stress are they putting themselves under? Provide as much support as you can, and that gives you a very strong negotiating position. Not only is it the right thing to do for that person, but it also means then that if it happens again, as it has in this scenario, that you can then go to that person and say, look, I don't know how to help you anymore. I've tried and I've offered you all the support I can, but now it's occurred again. Either you need to change, or else this is affecting me as a medical leader because I'm going around telling people that I'm providing support for you. And then if this keeps happening, then obviously that impacts upon what people feel of me as a medical leader. And it's really important as a medical leader that you set the tone and the culture for the organisation in terms of the medical staffing. So there's a really good book by Chris Voss called Never Split the Difference. He was an FBI negotiator. I'd recommend that book to many. It's a really interesting analogy in terms of how you might use negotiation within the workplace. And he talks about when the pressure is on, you don't rise to the occasion, you fall to your highest level of preparation. And I think being prepared for those meetings, having the information to hand, supporting the doctor, doing as much as you possibly can, and then at some stage, never splitting the difference, never compromising and saying, okay, well, look, it's okay if you have these occasional things, we'll put up with it. You have to, at some stage, put a boundary on it. And that's really important for the nursing staff particularly, but the staff more widely in terms of knowing that there's an acceptable standard and that VMOs are being held accountable to that standard.
So what options does the hospital have to constrain or discipline or alter the engagement structure with a doctor that is habitually disruptive?
Well, so in a public hospital, it's actually quite difficult to move on senior medical staff. So that requires board discussion and approval, and that can be a very long and protracted process. Credentialing in a private hospital is a little bit more flexible. There's a lot of doctors that come and go. Obviously, it impacts a doctor enormously if you change their scope of practice or if you actually say we're not credentialing you anymore. They have obligations to let their other sites know, and they have obligations to let APRA know as well if their scope of practice has been modified or altered by a hospital. So it's more around how do you think about negotiating with that specialist to actually say, if we go down a disciplinary route, this won't be good for you, it won't be good for us. Why don't we come to some kind of agreement between us about either altering the behaviour, providing the support you need, changing your working patterns, changing the cases you might do, or else thinking about actually has the time come that the association between you and the organisation needs to come to a close. And I always think, sometimes you see these things in the newspapers where people end up in court. I think if you end up in court, you've probably failed as a negotiator. I think you can generally negotiate your way out of certain situations. That said, there are always lines you can't cross. So, of course, there's mandatory notification criteria. If somebody's done something, sexual misconduct, inappropriate professional standards in the workplace, which are categorically unacceptable, then you can't accept those, and those are a hard boundary and you can't negotiate those. But most of the time when it's these kind of scenarios, you can try to negotiate to success in terms of what's a good outcome for the practitioner, what's a good outcome for the organisation and staff, and what you're trying to achieve as the medical director.
You raised credentialing. Credentialing occurs every 3 years and often is a opportunity for other staff to raise their concerns about behaviour. How do you differentiate between credentialing and performance management?
Yeah, so many people think of credentialing as the tick box exercise that is, I need to see your CV and your APRA and your medical indemnity and all the rest of it. But of course, there is a code of conduct which is expected by the medical board, and that is an essential part of being a successful clinician. Some clinicians think that they're very good clinically, and yet behaviourally there are altercations all of the time. And of course, to be deemed to be a very good clinician, you need to be a good communicator and to have good workplace relation with the people that you're working with. So I think it's important to say that you can use credentialing as a foundation for some of the discussions that you have around behaviour. And so it's interesting. I had a conversation with a VMO just yesterday where I said, your credentialing's due to come up for renewal early next year. Given the feedback that I've got from several nursing staff about the way that you communicate in the workplace, I wouldn't be providing support to those staff if I just automatically re-credentialed you. So perhaps you could suggest to me how you might think about how I might handle that and see if you can put that onto them. Quite often you'll find that they say, I can see that that's difficult and actually I may not apply for my re-credentialing next year.
I think it's a failure, perhaps, of a medical leader if you wait till credentialing. You think, well, credentialing is coming up next year, we'll deal with it then. Your experience?
Yeah, look, this is actually quite topical. So I've recently had a discussion with one of the VMOs who said, no, I won't be applying for reaccreditation next year. And there was a long silence. I always think, if you listen to Chris Voss's or read Chris Voss's book, you'll find that silence is a tool on your side because it allows the other person to talk themselves to where you want them to get to. And there was a long silence after I said that. And that VMO said, yeah, I think I won't be applying for reaccreditation next year. And I said, well, if you're thinking about not applying reaccreditation next year, perhaps you should think about finishing sooner than that, because otherwise we're just sitting and waiting for that to happen. And actually, after a few more conversations, that VMO said to me, yeah, look, I'll go and have a few conversations and let you know, but I think I'll probably cease in the next month or two. It's really important that you don't compromise patient safety or professional workplace relations while you're sitting out waiting to just get to that re-credentialing time.
Unfortunately, some very difficult clinicians don't have insight, and you can have those coaching, positive conversations with them, but they just don't accept it and appeal your decisions. What's the appeal process in a private hospital if the surgeons or the medical staff's not happy with your response or behaviour?
So there's a formal process. I mean, I think if you think about the way in which I've talked about things today, you can try to be very supportive and negotiate your success. Or you may, if it's really falling on the boundaries of what's acceptable, need to go down the disciplinary route. And there's normally a process for that in terms of the bylaws about providing in writing the allegations, that they have a time to come back to you and to contest that. And if your decision then is to not re-credential somebody or to cease their credentialing, then they can do that appeals process. And there is normally a formal appeals process, perhaps involving the CEO and some other, perhaps a member of the board or a member of the community advisory committee, for example. I tend not to hope to get to that situation. I think by negotiation and by preparing, and sometimes that is getting a legal opinion and getting an input to a letter that you might say to a clinician. Here's a letter that actually outlines the allegations. I'm not giving it to you today. I'm actually showing it to you. And you might want to have a think about whether you want me to send that to you next week. Quite often you'll find that if you just not play chess, because that sounds like it's a game and it's not a game, but if you checkmate somebody, quite often they'll come back with a letter that says, thank you for my time here. I think it's probably time that I move on. And I think that's always good if you can negotiate your way to success without actually going down legal channels.
One of the experiences that I've learned very early on is engage legal. They may not be upfront, they may not be in the conversation with you, but just checking that what you're saying, what your plan of action is going to work is incredibly helpful. There are lots of other staff involved. In this scenario, we've got the director of nursing, we've got the nurse involved. They're desperately leaning on you to take action. How much feedback can you give them about your conversations with the surgeon?
So obviously there's some confidential aspects to many of these conversations and you can't get into detail, but it's very important that they understand that appropriate action has been taken. And I think it's reasonable, perhaps not you as the medical director to have those conversations with those staff, but perhaps feeding back through the director of nursing, that the director of nursing and or that person's manager might be able to say, look, I want you to know that this got escalated and that appropriate action has been taken. You may not see the outcome of that action in your ordinary day interactions, possibly tomorrow, next week, next month, but I can reassure you that action has been taken and that there will be some significant outcomes coming from those discussions. And I think staff expect that. You did touch on medical legal. I think it's also important as well to keep the CEO informed of these kind of discussions. The CEO may need to let the board know there may be some media risk, and so it's important that the right people are aware of the conversations.
I think the head of department has often been in a very difficult situation for a long time. They've known about the problem but haven't had the courage or the expertise to confront the surgeon involved. So getting the other medical staff who work with this specialist can be very helpful as well. Private hospitals are in a unique position. They've got very clear missions, and particularly faith-based private hospitals may only offer or some services or not offer others. Can a private hospital choose what surgeons are able to do in their hospital?
Yeah, absolutely they can, of course, because they can decide themselves which contractors they want to have in their organisation and provide those services. And the visiting medical officers are contractors to the hospital. I think those discussions sometimes are driven by the mission and the values of the organisation. So there may be some things which are just not necessarily acceptable. So for a faith-based, not-for-profit organisation, there are some things which cannot be provided. And those are discussions that need to be had with the VMO to say, look, you want to be credentialed here, but unfortunately we just can't provide those services. For others, it may be that you need to think about profitability and is that something that you want in a private hospital? I think faith-based and not-for-profit organisations are different for-profit health organisations. So, for example, if a patient comes in, they may not have private health insurance to cover what they need doing. In particularly mission-based organisations, we will provide that care and then, of course, sort that out afterwards, whether that's transferred to a public hospital. In terms of the services that are provided, it's more about working with the surgeons in terms of finding ways to make the operations or procedures that they're doing profitable.
Profitability is a really difficult issue, particularly in private at the moment. We've talked about a doctor's skills, we've talked about a doctor's behaviour. What about a doctor's efficiency? Not turning up to theatre on time, taking a long time to do a procedure that leads the hospital to lose money. How do you deal with that financial contribution in the context of surgeon engagement?
Yeah, it's an interesting question, and one, of course, David, that you would know from years of working with surgeons about performance and data and activity data. I think many surgeons in the private sector are interested to know how they compare with their peers. Clearly, starting theatre late every day is going to be an issue which you'll tackle almost as a behavioural conversation. But if it comes down to long operating times or perhaps using tools or instruments that others aren't using, and it becomes around variation in clinical practice, then that's another angle. My experience has been that most surgeons are open to those discussions. They're not particularly open to the discussion that goes along the lines of we don't really make money from what you do and so we're not interested in you being here anymore. They don't respond well to that, and so that's not a successful way to set yourself up for those conversations. But if you actually engage a surgeon and you say, look, I'm struggling a little bit with this, clearly there are some parts of the organisation that make money and there are some parts that don't. And clearly some aspects of a private hospital, perhaps ED, palliative care, some of those kind of areas, they're very important for a hospital and they don't necessarily make money. And it's really important that we have those clinicians. But for many of the surgeons, they're interested to find ways that actually their cases are profitable for them. My experience has been that many surgeons know their own finances, but they don't necessarily understand how the hospital finances are working. And so they presume that if they're making money off a case, then the hospital is as well. And of course, we know that that necessarily isn't the case. So sometimes it's around just education and having a gentle discussion with those surgeons. And I find that over time, they generally change.
Matt, You decide the specialist behaviour is patients at risk. You come to an agreement that they'll move on. How much of that information can you share with the next hospital that rings you up and says, hey, Matt, why did this guy leave your place?
Yeah, so that's very difficult, and you need to be very careful with this because there are things that are able to be communicated between organisations and things that can't, and particularly relating to detail and confidential discussions. I think organisations generally have a good understanding from others if there have been behavioural issues, and that's not because necessarily there's inappropriate conversations being had, but because many clinicians work across different sites. I do think you have a responsibility at the hard lines of those boundaries to actually say, no, I need to let the medical board know about this, or I need to let another organisation know about this. You need to be very careful not to divulge confidential aspects of discussions, but patient safety is very important, and you mustn't just feel that your obligation's done when they leave your organisation if you believe that it places other patients at risk in other organisations.
I think that's absolutely critical, is to have discussions with the surgeon at the time that they make the decision to leave about what you're going to communicate and who you're going to communicate with.
Yeah.
Matt, any final thoughts or observations about the scenario?
Look, I think it's a common scenario, and it's one that many medical administrators deal with on a regular basis. My take-home message is be as supportive as you can, listen as much as you can, provide support, reassure staff that you're taking the appropriate action, and negotiate your way to success. Sometimes, although things are immediate and you need to have that discussion immediately with the VMO, as soon as you've had that immediate discussion, take your time, let that clinician come to the place that you want them to get to in terms of what they're open to and what they can agree to in terms of changes in their professional practice. And I've been astounded by some clinicians who come back and say, look, I can't believe that I did that. I think it was acceptable 20 years ago, but now I realise that actually the way that I've been behaving in theatre is no longer acceptable. And I'd like to pay for myself to go off on a course and to do some education and training. And they've initiated that and then come back with the completion reports. And I've congratulated them, and then they've become your second champions. So they go to the theatre environment and they say, you know, I was like this, but actually you can't be like this anymore. You need to moderate your behaviour or the way in which you're interacting with staff. And so that has that ripple effect in terms of improving the culture within the organisation. And so I think gentle and supportive is much better than disciplinary.
Thank you very much, Matt, for a great conversation.
Thanks for having me, David.
That was Professor Matt Sabin, most recently the Group Director of Medical Services at a large private hospital in Melbourne. And that brings us to the end of this episode of Safeguarding Healthcare. I'm Dr. David Rankin. Follow Safeguarding Healthcare free on Apple Podcasts, Google Podcasts, Spotify, or wherever you listen to podcasts. This podcast is produced by Sound Cartel for the Royal Australasian College of Medical Administrators.